it's a popular thing to learn right now, I guess, EUS. And well, thank you all for joining in. Okay. All right. And I'm going to request, okay. So we can start off with Jayanta, if you would like to share your screen and
yeah, I'd share my screen. Is it visible now? Yeah.
Yeah.
Okay. So that's fine. Thank you. So at the outset,
all right, thank you.
Begin. So at the outset, I'd like to thank Dr. Saurav Mukhewar and Midas Medical Foundation for starting this very interesting thing called the EUS for beginners. So we'll try to go. This will be something which will be very important and significant for people who wants to learn EUS. So today I'll be discussing the very basics of endoscopic ultrasound, what we understand, how the ultrasound works, and how we are kind of try to optimize the images that we gain during the procedure. What are the kind of various kind of indications and what are the preparations and the adverse effects. So as we all know that EUS or endoscopic ultrasound, as we know it, has traversed a very long distance in the last 40 years. The first EUS probes and the instruments had come way back in 1979, 1980s. From there, in the last 40 years, basically has gone a very long, a very steep kind of, I would say, an evolution from just a mere diagnostic tool to a therapeutic modality. It's basically a combination of two technologies. One is a fiber optic endoscopy and the other is the ultrasound. So they have combined the two technologies of viewing the GI tract and also doing an ultrasound in the same system in order to enhance not only the diagnostic capabilities, but now even for the therapeutic capabilities as well. We go inside the GI tract and EUS helps us to gain a very good and a high resolution real-time imaging. So two important aspects. One is a high resolution image, better imaging, and also it's a real-time imaging. As we kind of move the scope, we can see the images real-time. So as I have been assigned the task of discussing on the principles, the indications for EUS, what are the basic preparations that we need to give, and definitely what are the adverse events. I would like to highlight more on the principles of EUS. So whenever we talk about EUS or even for that matter, a transabdominal ultrasound, the key thing is piezoelectric crystals. What are these? These are basically crystals. Whenever we pass an electrical impulse through them, it generates ultrasonic waves. That ultrasonic waves traverses the tissue, hits the tissue, gets reflected back, and that is how the whole image is generated. So what happens is, even for a transabdominal ultrasound, there will always be, just behind the matching layer, there will be a channel or a layer where the piezoelectric crystals are kept. So what happens is, when an electrical impulse comes, the piezoelectric crystal starts vibrating. It generates the ultrasonic waves that goes through the tissues, traverses the tissues, gets reflected variably from various parts of the tissues in various frequencies, hits again the piezoelectric crystals, and then that again gets transmitted into an electrical impulse and gives us an image on a monitor. So basically, these piezoelectric crystals acts both as a sender of the ultrasonic waves as well as the receiver. So similar kind of a thing happens in an EUS. So we have a EUS processor. So once an electrical impulse is generated into the transducer, it excites the piezoelectric crystals, which generates the ultrasonic waves, which hits the tissues. Once it hits the tissues, what happens is, ultrasonic waves are just like light waves. So it undergoes reflection, refraction, and various kinds of behavior while it traverses to various tissues. And once it has traversed to various segments of the tissues, it gets reflected back, refracted back, some of the part gets absorbed, and as a result of which, after which the reflected waves then again hits the transducer, after which it again goes back to the transducer, the processor, and we generate an EUS image or an ultrasonic image. So this is the very basic principle of how an EUS image acquisition occurs. So the strength of the impulse that we find on the monitor, or the color of the color of the pixel, is basically directly proportional to the strength of the impulse that gets generated from the tissues. So anything which is white has the highest or the strongest amount of reflected impulses. When there is no reflected wave and everything traverses through the tissue, we get a black or a no signal. Some pointers before I go into the basic, into the actual principles of EUS is that acoustic impedances differ among tissues. So if there is a fat, a bone, or tissue, or a malignancy, the impedances will differ between these various tissues. And this is the basic principle on the basis of which basically the EUS image acquisition occurs. So as they reflect from various impedance of the tissues, they generate a difference in the electrical impulse, and that is how we get an image. So, and these EUS waves that I had already mentioned undergoes reflection, refraction, and scattering. Whenever there is an irregular surface, let's say the neoplastic lesion, there will be more scattering, which will cause a difference from the surrounding tissues, and that helps in leading to differentiate that particular area from the remaining areas. And definitely the quality of the image will depend on the amount of the reflected waves. So I will, in my subsequent discussion, will tell you how to maximize this image that we acquire from the EUS procedure. So the transducer, one of the important aspects of maximizing this image is to, if the transducer is perpendicular to the target tissue, because if it is perpendicular to the target tissue, it hits directly onto the tissues, gets reflected, maximum waves gets reflected back, and hence we can kind of maximize the image quality. Another important phenomenon that occurs is known as absorption. So a good amount of the ultrasonic waves gets absorbed into the tissues. That will depend on how much the absorption occurs. It will depend on the viscosity of the tissue and the frequency of the sound as well. So absorption will lead to some amount of loss of the ultrasonic waves. So as a result, when we increase the frequency, we increase the resolution, but because of the absorption phenomenon, the penetration depth decreases. So what happens is, because of the absorption, there's a good amount of loss of the ultrasonic waves. And as we go on increasing the frequency, the resolution increases, but the penetration decreases. I'll come to in details slightly later on. So the principle is very simple. We use a transducer I had just described. Earlier, the transducer used to be a single element which had to be rotated by a rotor in order to obtain a 360-degree image. But these single element transducers are no longer available. Whatever we have in modern times are the phased array transducers. So that is the reason why you will always hear people talk about a radial array echoendoscope or a linear array echoendoscope. This array is basically the principle of the transducer that is being used. It's a phased array transducer. So people might often ask the question as to, if we have a conventional ultrasound, then why do we need an EUS? So what is the advantage of EUS over a conventional ultrasound? Conventional ultrasound has to traverse through the skin to our abdominal fat, and there is a lot of amount of intra-abdominal or intraluminal gas that is there, which can interfere with the ultrasonic waves. And there is also the presence of fat and bone. Gut wall acts as a very excellent window. It is very close to the structures that we need to examine. Let's say a pancreatobiliary structure, or let's say just outside the mediastinum we need to observe. In those situations, what happens is, if we place the transducer inside the gut wall, inside the gut lumen, and it gets very closely proximate to the gut wall, and hence it enables us to get a better picture of the immediate surrounding structures of the gut wall. And another advantage of the EUS is that it has a suction port, so we can suck out all the air, which is one of the major deterrent, or which is one of the major hindrance to get a very good image on a conventional ultrasound. So it gives a very, very good window for a pancreatobiliary imaging. In fact, EUS is one of the very accurate imaging modalities for pancreatobiliary imaging, over and above the other imaging modalities available. And it gives a very high resolution image because it is very close to the field where we want to actually observe or see get the image. So what are the instruments that are available for EUS? This is some image that I have taken from some papers way back in 1979, 1980s. You can see how these very early prototype EUS scopes were there. These were all those single element transducers which had to be rotated, which has to be used using a motor in order to rotate the transducer in order to get the better image. Nowadays, we have two kinds of basic instruments. One is the radial echoendoscope and the other is the linear echoendoscope. What is the difference between the two? A radial echoendoscope was the first generation of echoendoscopes of the modern times, where the ultrasound transducer gives an imaging plane of a scanning image of 360 degrees. So basically what we can get a 360 degree scanning image of the ultrasound. These echoendoscopes are oblique view, forward oblique view echoendoscopes. So it acts just like a siding endoscope. The camera is on the side and the transducer is fitted at the tip, and it gives a 360 degree ultrasound scanning image. The depth of the field is around 3 millimeter to 100 millimeters, and the working channel diameter is just 2.2 millimeters. I'd like to reiterate the fact that radial echo endoscope primarily is for only diagnostic purposes. It does not have any therapeutic purposes, and even FNA or FNB cannot be done with a radial echo endoscope. For that, what we need is a linear echo endoscope. So for a linear echo endoscope is something which gives an ultrasound scanning image of 180 degrees. It has all the various features for which it can be used both for diagnostic as well as for therapeutic purposes. It is again has an oblique view, oblique forward viewing camera, and the depth of field is similar as that of an radial echo endoscope of 3 to 100 millimeters, and the working channel diameter is 3.7 mm, and hence it can be used both for diagnostic as well as therapeutic purposes. As of now, the role of radial echo endoscope is very limited. In fact, if someone, as a beginner, if someone wants to learn echo endoscope, one should learn the linear echo endoscope anatomy rather than spending time on the radial echo endoscope. As of now, I think the radial echo endoscope has a role only probably for examining the gut wall properly. If there is a submucosal lesion, let's say you want to examine the wall of the esophagus, in those situations, probably radial echo endoscope will score over and above a linear echo endoscope. And definitely, if you want to do a diagnostic rectal EUS, in those situations, probably a radial echo endoscope scores over linear echo endoscope. Other than that, linear echo endoscope is self-sufficient for both the diagnostic as well as the therapeutic purposes. So these are the various scopes available from various companies. We have the Olympus, the Pentax, and the Fujinon. Primarily, we are habituated to using the Olympus and the Pentax scopes. There is one kind of EUS probes that are available, which are known as the catheter probe EUS, catheter-based EUS probes. These can be, these actually kind of, they have a rotor at the tip of the probe, and these catheter-based probes are basically are used through the working channel of the endoscope. So when you put an upper GI endoscope, you can push these catheter-based probes of the EUS through that working channel and kind of target a specific lesion or a small, let's say a gastric lesion, or maybe there is an esophageal stricture which you want to examine. So this is kind of an esophageal stricture where a catheter probe, or also known as a mini probe EUS, is used to examine the intricate details of the wall of the characteristic lesion of the wall. The usual range that is available for these kind of mini probes are 7.5 to 20 megahertz, sometimes even 30 megahertz are available. They give a detailed imaging of the GI wall layers, and these are also used for biliary and pancreatic intraductal ultrasound. So the same probe can be used both for imaging of the GI wall layer, let's say for a small strictures, for a small submucosal lesion, and these same probes can be used for pancreatic and biliary intraductal ultrasound. Coming to the basic EUS processors that are available, we have the Olympus UME2, the Aloka system for the Pentax, the Hitachi system. For all practical purposes, we use the Olympus system of the UME2 or the Pentax system with the Aloka system. So I'll now go into slight details of how does a working end of a linear echo endoscope works. So this is the ultrasound probe that is there at the tip. This is the camera that we can see over here. For the disposition of the camera as well as the working channel and the elevator is exactly like a side wing duodenoscope. Just you can imagine that this is basically a part of a side wing duodenoscope above which a transducer has been attached. If you see a lateral view, you will find there is a groove over here where we attach the balloon. So we use this balloon for inflating water in order to reduce in order to get a better echo interface between the transducer probe and the gut wall. So in order to get a better, maximize the EUS image. For all practical purposes, the balloon is used more with radial echo endoscope as compared to a linear echo endoscope. And this is how, once you pass a needle or an accessory, this is how the accessory comes out of the working channel of the echo endoscope, and this accessory can be slightly modified, kind of manipulated with the help of the elevator, just like we use in cases of ERCP. So now we need to understand as to how to use the echo endoscope to optimize your image acquisition. This is important because we are trying to do two things. One, we are trying to search for the lesion first, and once we have found out the lesion, we need to characterize the lesion. So for searching of the lesion, we need a deeper and a wider scanning of the tissues, and a sharper images to avoid artifacts. And then once we have targeted the lesion, then we need to focus on the characteristics of the lesion, and we need a higher resolution image of the lesion in order to characterize the lesion and also avoid the various artifacts which can lead to a false impression of the characteristic of the lesion. So what are the various things that we can adjust in order to get a better tissue imaging? So this is the representative photo of what you can see is the keyboard of the Olympus EU-ME2. And what are the various things? There are various buttons that are available over here, using which we can kind of adjust the various image qualities of the EUS image that we get, and as a result, optimize our image interpretation. So what are the various things that we basically use? We can adjust the frequency, gain, contrast, the focus of the image, the depth of the image, and definitely a very common function is the Doppler image to look for the vessels. I will not go into the details of various other image enhancement techniques such as elastography and contrast enhanced EUS, because that is completely a different talk altogether. So first I'll go with frequency. So we have a range of frequency with the echo endoscope, starting from 5 megahertz, 6 megahertz, 6.6 megahertz, 7.5 megahertz, 10 megahertz, and 12 megahertz. So this is the range of the frequencies that we get. We can adjust that with this button over here on the keyboard. We need to understand that as we go on increasing the frequency, the resolution increases, but then the depth of the penetration decreases. As I've already mentioned earlier, that this occurs because of the phenomenon of absorption. So if we want to get a better resolution image, we can increase the frequency, but at the cost of the penetration. So this is where I can show you that at 5 megahertz, you can see that we can see at the further depths of the EUS image. But as we go on increasing the frequency, the distal part of the field of the echo of the EUS image becomes blurred. But on the contrary, we get a much better resolution of the image. So what we do is we adjust the frequency, higher the frequency, better the resolution. So we can see over here at 6 megahertz, you can see this kind of an image. As we increase it to 12 megahertz, we can get a much better resolution of the characteristics of the lesion. So probably what you can do is when you want to scan the EUS, when you want to scan the field, you can use a lower frequency so that you get a better depth, better penetration, better depth and better penetration of the tissue. So you can know whether you're missing a lesion or not. Once you have found out the lesion, then probably you can go on to a higher frequency in order to properly delineate the characteristic of that lesion. Next, we come to gain. What is gain? Gain is as simple. We increase the gain, we make the image much more brighter. So as we increase the gain, this is where you get the scores of the gain. So here you can see it's 9. So this is a small gist that you can see. At a lower gain, this appears darker. As we increase the gain, it becomes very bright. The problem with a high gain is that although it increases the brightness, but this leads to a lot of noise, this adjacent noise which we do not need. And on the contrary, if we use a lower gain, it gives a much lower noise, but again, we tend to lose structures. So what we need to do as an endosonographer is to adjust the gain in order to optimize the image so that we get the best characteristic of that particular lesion that we are trying to demonstrate or trying to find out. This can differ from lesion to lesion, and this improves as the endosonographer goes on learning as to how to adjust the gain. Next comes the contrast. As we all know, even on a TV remote, we find the contrast. We increase the contrast, we get a much sharper image. We need to adjust the contrast in order to optimize the image. So these are the various kinds of image, and these are the various kinds of buttons, or these are the various kinds of features of EUS which are needed to use in order to optimize the image so that we can get hold of a better characteristic of the image that we are trying to get, because that will help us in better delineation and interpretation. There's one thing called a spatial time compensation, or which is also known as the time gain compensation. What is this? So as the ultrasound waves goes deeper and deeper into the deeper tissues, what happens as it gets reflected from the deeper tissues, it tends to lose the amplification. So as a result, we get much darker kind of images from the deeper tissues whenever we look into an EUS image, right? So what needs to be done is, what we need to do is, if we want to visualize, let's say, a deeper tissue which we are not able to reach adequately with the EUS probe. In those situations, what we use is known as a spatial time compensation. What it does is the processor kinds of amplifies the reflected waves from the deeper tissues, as a result of which we get a much better visualization of the distal part of that EUS image. So when at default mode, you'll find something like this. This is at where at default mode at various points at 0, 3, 0, 1, 2, 3, 4, 6 centimeters at various depths, the setting is kept at 0. Let's say once, and we want to visualize a deeper tissue and want to enhance the image that is getting reflected from the deeper tissues. Then we go on to this STC menu, or the spatial time compensation menu. You will find this kind of various depths are mentioned. So let's say we want to find out, or we find that there is a lesion and we want to better visualize that lesion, but it is, let's say, at the level of 3 centimeter or 4 centimeter. Then what we do is we increase the STC compensation over here, and then what we find out that you'll find that at 3 centimeter there is an increase in the amplification of the reflected waves. So that will help in better visualization of that level of the tissues that gets that level of the image. So let's say this is a contrast enhanced EUS that is being carried out, and this is the default mode that is there. And you can see clearly that on after the contrast has been injected, we cannot actually, because this is a large lesion, we are not able to kind of understand what is the contrast enhancement pattern at the distal part of this lesion. So what we do is we increase the STC at this level. So once we increase the STC, you can see over here, once the STC has been compensated, now you can clearly see what is the contrast enhancement pattern of the distal. So this is the advantage of a spatial time compensation, where we want to increase the reflected waves, amplify the reflected waves that comes from the deeper tissue in order to get a better image of the deeper tissues. Then comes the depth. Depth is another function where we use the focus depth in order to increase the resolution at the desired depth. So basically what happens is ultrasonic waves behaves just like light. So we have all read in the physics of light that there is a focal point. So what we do over here is we set the focal point at specific levels at where we want the resolution to be the best. So as we keep on increasing the focal depth, that is the place where we get the best resolution of the image. So if we want to visualize a deeper tissue, we probably kind of set the focal depth at a depth, and whenever we want to kind of have the focus depth or the resolution at a superficial tissue level, then we decrease the focal depth. So this is how we adjust the focus in order to achieve a better resolution. Next comes the function of the Doppler. Everyone is aware of this Doppler function. This is available on the keyboard with 3 modes. One is the B mode, the flow Doppler or the routine Doppler mode, and then there's the power Doppler mode. So once we switch on the power Doppler mode, what we get is that the vessels we see the flow inside the vessels, and we can identify the vessels adequately and the flow therein. We can adjust the Doppler mode again with these kinds of various buttons that are available. We can increase the flow gain or decrease the flow gain. What happens many times, we must have observed that once we switch on the power Doppler, the flow of the power Doppler seems to go beyond the margins of the vessels. This is known as blooming artifact. We can sometimes decrease the blooming artifact by decreasing this flow gain. There are various kinds of other modes that are available, like the power Doppler mode, the high flow mode, which can be used in order to modify the Doppler waves that we are trying to interpret. Another important aspect of EUS imaging is tissue harmonics. What is tissue harmonic? Basically, there are a lot of waves that are being generated by the transducer, hits the tissues and comes back. So the fundamental echo signals that we have are those which are generated by the transducer. And then there are certain echo signals which are generated particularly by the tissues. Those are known as the harmonic echo signals. So once we switch on this tissue harmonic echo signal, what happens is that these signals that the transducer is receiving gets filtered, and only the harmonic echo signals which are generated by the tissues gets captured by the transducer and gets reflected. So this option is available on the keyboard. Usually by default, it is in the off mode. Whenever we want to switch on the tissue harmonic mode, we can switch on to the THEP or the THER and get the tissue harmonic mode. So what happens is, once we switch on the tissue harmonic mode, it gives a much better resolution of the image, and decreases the noise. The adjacent noise that is there because of the fundamental echo signals decreases, and we get a much better resolution. But this is definitely at the cost of the penetration depth of the image. So this is, I'll give an example. Let's say we are observing a bile duct or we are observing a gallbladder, and we find that there are some noise artifacts over here and we're not sure, or even for that matter, when we try to observe in the gallbladder and we found that there is kind of a sludge-like material, we are not able to make sure what is the, whether it is an artifact or is an actually a sludge. We switch on the tissue harmonic and we can get a much better clear picture because the artifacts gets reduced, the noise decreases, and we get a much better resolution of these kind of images. So this is an important use of tissue harmonic where we want to kind of get a better resolution in these kind of anechoic structures, where a lot of sounds kind of is disturbing. Many times what happens is I'll come later on, there is a very common artifact which is known as a side lobe artifact. These things can be reduced with the use of this tissue harmonics. Now I'll come to artifacts as I was talking about. Once we have gone through these basic modes, how we are kind of switch around all these kinds of modes in order to enhance the quality of the image, we need to understand at the same time what are the various artifacts that appears, because these artifacts needs to be interpreted in a fashion in order to be able to characterize the lesion. So there are various two groups of artifacts. One is the propagation group artifact and the attenuation group artifact. So propagation group artifact includes reverberation, ring down artifact, refraction artifact, mirror images. There are various other artifacts have been mentioned. I'll go through some of the basic artifacts that have been described. And when we talk about attenuation group artifacts, we talk about shadowing artifacts and enhancement artifacts, right? So what is reverberation artifact? Reverberation artifact is nothing but whenever between the transducer and the luminal wall, some amount of air gets trapped, it leads to multiple echoes over there. This is a very common artifact which we found over when we are using a radial echo endoscope. Some amount of air or fluid gets trapped, and then what we have is there is multiple, the waves are getting reflected multiple times within that small space, and we get these kind of ring kind of artifacts. This is known as a reverberation artifact. We can decrease these kind of reverberation artifacts by using a balloon when we are using a radial echo endoscope. What is ring down artifact? Ring down artifact is another very commonly encountered artifact which occurs because there is a resonant vibration, because air bubbles get trapped because of the trapping of the waves within a small air bubbles. This is known as what is known as resonant vibrations or ring down artifact. These kind of things happens when we, let's say, when we are trying to visualize the bile duct, when we are trying to visualize the intrahepatic biliary radicals, and that is pneumobilia. So then you get this kind of a ring down artifact. So then you know that probably, yes, there is air getting trapped within that duct and leading to this kind of an artifact. Mirror image. Mirror image is a very, very common artifact which comes when you are doing an EUS. This primarily occurs because there is a very probably highly reflective surface which acts as a mirror. This happens when you are doing an upper EUS. It happens when you are visualizing the diaphragm, and when you're doing a rectal EUS because of the interluminal gas. I'll show you a video of this. You can see this is the transducer, and this is the reflection of the transducer, which is acting just like a mirror image, as if this is the mirror, and the mirror and the image of the transducer is getting reflected over here. This happens because of interluminal gas and air. So the best technique to kind of avoid this kind of mirror image is to insufflate more fluid, suck out all the air bubbles, and sometimes use a balloon in order to avoid this kind of mirror image. But these kind of images can occur, which gives a false impression of probably some lesion occurring over here. But this is nothing, but this is just a mirror image. Acoustic shadowing is something which we are very, very familiar with. We commonly find any kind of calcified structures which is highly reflecting. It leaves a shadow behind it. It's known as acoustic shadow. We see gallbladder calculi, we see pancreatic duct calculi with a lot of shadowing. This is acoustic shadowing. What happens with acoustic shadowing is that the light, the ultrasound waves hits the calcified structure, gets reflected back, so it shows bright, and there is a shadow behind it. Just the opposite of this acoustic shadowing is what is known as acoustic enhancement or posterior acoustic enhancement. What happens is, if there is an anechoic structure or an attenuated structure, then what happens behind that structure, there is an enhancement of the tissues. This is not abnormal. This is not abnormal as compared to the rest of the tissues. This is known as acoustic enhancement, is because of this low echoic structure which is just ahead of that acoustic enhancement area. So these are the various basic artifacts that I've kind of discussed. So so here ends my discussion on the principles. So I've discussed about what are the various buttons that we can use to enhance or the image quality, what are the various artifacts we need to look for, and I'll come to the indications. I think indications for EUS is something which every gastroenterologist today, starting from resident to faculty, everybody is aware of. there are two broad category of indications. One is either your diagnostic indications, and then there are therapeutic indications. So for diagnostic indications, I'm not going to the details. Everybody is aware of diagnostic indications. We have an esophageal lesion. There is an esophageal malignancy, a carcinoma. We need to stage those lesions. We need to find out. We need to characterize the esophageal wall. We use an EUS. We need to characterize the character of the stricture in the esophagus. We can use a mini probe. Various kinds of gastric lesions, whether it's a gastric tumor, a lymphoma, a subepithelial lesion, a submucosal lesions, we can use the EUS to better characterize the lesion as compared to the other modality of imaging. Biliary pancreatic pathologies, probably EUS is one of the forerunners in today's day for diagnostic purposes for biliary pancreatic pathologies, and can score over at many situations, can score over CT and MRI in these situations. Definitely another important indications, diagnostic indication is lung malignancies. There are various stations of lung cancer staging where the EUS can be used, such as on stations 5, 7, 4, 8, where we can use EUS can be used for lung cancer staging as well. And definitely as a part of the diagnostic, once we have diagnosed the lesion, we need to sample the tissue. Again, EUS is used for tissue sampling, be it FNA for various cystic lesions, or an FNB for any kind of solid lesions. Even liver biopsies are currently being done routinely to kind of EUS is used for getting a good tissue in EUS liver biopsy. Now I'll come to therapeutic EUS. Therapeutic EUS, the indications have broadened, and the spectrum is ever increasing in the field of therapeutic EUS, starting from fluid collection drainage, be it any kind of pancreatic fluid collections, be it pelvic fluid collections, pelvic abscesses, any kind of abdominal fluid collections, to ductal drainage, both the biliary and the pancreatic duct drainage. If the routine ERCP fails, then the ductal drainage can be done. Then comes to celiac plexus neurolysis or block for patients having pancreatic cancer, chronic pancreatitis, to really alleviate the pain. Then comes the various kinds of indications for vascular interventions, primarily two broad categories. One is we talk about variceal coiling, and the other we talk about is the pseudoaneurysmal coiling. These can be done, and definitely various anastomotic procedures are now being done using therapeutic EUS, starting from gastrojejunectomy, jejunojejunectomy, and even gastrogastroscopy, such as the edge procedure. So the spectrum of therapeutic EUS is gradually over the years have increased paramount as we go ahead. So this is one of the probably the basic EUS therapeutic procedure, which is the fluid collection drainage. This is a pancreatic fluid collection, one drainage we commonly use. We puncture with a needle, we pass a guide wire, and then we place the stent. Again, various kinds of abnormal collections, such as this is a biloma that has been drained using EUS guidance, and this is the inside of the biloma that we can see. Coming to EUS guided ductal drainage, we all know about EUS guided biliary drainages. Again, there are various patterns and techniques of EUS guided biliary drainage. This is something which we will not go into. There is EUS guided hypergastostomy, EUS guided antegrade stenting, EUS guided politicoduodenostomy, EUS guided rendezvous technique in those situations where there is an accessible papilla but you are failing an ERCP. So there are various kinds of techniques and procedures that are available for draining the duct using EUS. So this is EUS guided hepatogastostomy. You puncture in the intrahepatic duct, and what we are trying to create is a permanent kind of a fistula between the left ductal system and the stomach, and then we place a stent and help in drainage of the intrahepatic biliary radicals. Again, EUS guided politicoduodenostomy, we position the EUS scope in the duodenum and then drain the CBD, placing a stent. Similarly, EUS guided antegrade stenting can sometimes be done. Let's say the papilla is not reachable, but then the lesion is lower down, close to the papilla. We puncture, similar, just like the EUS, we puncture the intrahepatic ductal system, we dilate the system, and then we kind of place the stents. Similar is the EUS guided rendezvous procedure. It's just a procedure which kind of helps in aid in the ERCP. EUS guided pancreatic drainage similarly can be done. So basically the indications for EUS interventions has been increasing in leaps and bounds, and various kinds of interventions can be done in the gastrostomies, etc., etc. So now I'll come to the various kinds of upcoming interventions that have been coming up. Pancreatic cyst ablation is something which is now being regularly being done using RFA probes. Even various kinds of pancreatic entities are being used with RFA probes, and various kinds of upcoming interventions such as cancer therapy in the form of chemotherapy, brachytherapy, fiducial marker placements are now in the experimental stage, but again are the future of EUS interventions. How will you prepare? It's very basic preparation. For all upper GI US procedures, you need to keep the patient NPO for 6 hours. A pre-procedure evaluation definitely has to be done. So you need to define what are the basic investigations, why do you need to do the US procedure, and definitely then you need to get hold of your anesthetist and what kind of sedation and anesthetic assessment has to be done. What are the risks for the anesthesia if the patient is to be done under propofol sedation or maybe a general anesthesia. Coagulation profile might need to be seen if you're planning for an EUS procedure where you're diagnostic EUS where you're planning for an FNN or an FNB as well. We need to look into the previous medication history as to whether the patient is on some anticoagulation medications or not. Prophylactic pre-procedure single dose antibiotic needs to be given if we are planning for, let's say, a pancreatic cyst aspiration, etc. And most important is an informed consent. Informed consent will definitely be one of the key things which we need to do before you undergo any procedure for that matter. For rectal EUS, again, a routine bowel preparation as you go for a colon. Sometimes a scoring may be used, whether the bowel preparation is adequate or not. And definitely the remaining things remain the same, a pre-procedure evaluation, sedation, coagulation profile, and informed consent. When we talk about therapeutic procedures, again, the similar kind of things occurs. We keep the patient NPO for 6 hours, pre-procedure evaluation, coagulation. But the most important point for therapeutic EUS is we need to understand that EUS therapeutics, although it's one of the safest kind of therapeutic procedures, but it has its own catastrophic complications. So some of the things which need to be more emphasized is an informed consent. You plan with your technician as to what are the steps you need to go, you're going to do, so that your technician is in sync with you during the procedure. Check for all the accessories, whether they're working or not. Keep a backup of the accessories. And definitely, and most importantly, for procedures such as US guided biliary drainage, US guided pancreatic drainage, and even for US cystogastroscomies, inform your surgery and radiology colleagues for backup. Adverse events, if you are talking about a diagnostic EUS, it's as safe as any routine diagnostic upper GI, lower GI that we talk about. The complications will be similar, like perforation, bleeding, need for surgery. So for diagnostic EUS, the safety profile is very similar to any routine investigative procedure. But for therapeutic procedures, yes, the adverse effect profile percentage is pretty high. For biliary drainage, ranges from 15 to 30%. For cystogastroscopy, 10 to 15%, and gastroenterostomy, 12 to 20%. So for these situations, we need to understand for therapeutic procedures, the patients needs to be primed and counseled very well, and all the various adverse effects that could be there should be kept in mind, and you should always have a backup as to what to do once things starts going wrong. So to be a good endosonographer as a beginner, I would like to put across some take-home messages. Believe that US is not difficult, as we need to understand that we are all DNB, we are doing DMs and DNBs and GI surgeons. We are not radiologists, so we are not very well aware with these kind of gray and white images. And initially, when you start doing an EUS or you stand behind your mentor trying to learn EUS, you always find it's very baffling that there is so much of the gray and white images. You're not able to understand why. You need to give more time, and you gradually will be able to understand and interpret an EUS image. So you have to believe that EUS is not difficult. You need to know your equipments. You need to know your processor, how you can optimize the image quality. And if you have to learn one, I'll reiterate the fact you learn linear US anatomy, as Dr. Saurabh will just now subsequently kind of give a brief introduction about it. Familiarize yourself with the gray-white images. Do not rush. Once you have trained yourself in endosonography, you're going to do US all your life. So please learn diagnostic US first. As I'm sure that all the panelists, including Dr. Saurabh, will agree with me that diagnostic US is 10 times more difficult than a therapeutic US. You need to understand and learn your diagnostic US before you harp on going ahead with the therapeutic US, and watch and learn from your mentor, because Rome was not built in a day. Thank you.
Okay. Well, thank you, Jayanta. That was a fantastic lecture. Sorry, I think I gave you less time to give, and you did manage to squeeze in a lot of important information. And even that was a bit of a learning for me as well, because there are things that there are sort of newer technologies coming in, and it's great to learn from you. Thank you. It was a great talk. And I totally agree with you that I think the learning curve for EUS is diagnostic EUS is longer than actually therapeutic EUS. Actually, once you reach a stage of doing FNAs comfortably, therapeutic EUS probably takes you 5 or 10 procedures. So diagnostic EUS takes you like 200 or 300 or 400 procedures to get proficiency. So thank you for that. All right, what we'll do is I'm going to switch gears and for people who want to do it or have been doing a little bit of it, I'm just going to share with you some basic tips, techniques on how we do basic upper EUS examination. And as Jent also mentioned, we'll be doing linear EUS, and that's what we all do. I do personally love radial EUS, but again, with lack of applications and changing scopes, everybody's sort of moved towards doing linear EUS. Only in certain conditions, like what Jayanta mentioned, epithelial, subepithelial lesions and rectal lesions where radial can actually play some role. Linear EUS seems to do the job pretty well. Okay, so what I'm going to start off with, hopefully I'm full screen now, and if you guys can see it, yeah. So, okay, so today we'll go over just some basics of mediastinum, EUS, subcanal space, AP window, liver with the vasculature, pancreas, head to tail, spleen, kidney, adrenal gland, celiac axis, gallbladder, common bile duct, and how to identify these structures, how the EUS is performed, how do you move the scope, and everybody has a different style. I'll look forward to having Jayanta's and Shankar's views as well on this. Okay, so just a few basics. I think it's important as you start doing it. There has to be a systematic approach as you go about doing an EUS. Don't rush into it. You have to recognize that there are certain sort of stations as have been described, and you need to know the important landmarks. So there are certain areas across the gastric and duodenal lumen where you'll find certain organs and vessels, and you have to sort of stick to that. Just having a non-systematic approach will lead you to lose and miss out on structures, and that's why it's important to go step by step. And all right, so if you lose the way, so you're finding something, you lose the way, you may want to go back to the station where you started from. Okay, so for example, which we'll go through, you're at celiac, and then you find the neck of pancreas, and then you lose it and you don't know where you are. So you have to again go back to the aorta, find the celiac axis, and then restart the process. Okay, know what is normal. Okay, because I think I probably must have at least seen 100 EUS examinations being done to just understand what is normal before I even started touching the scope. It's only then that you'll understand what is abnormal. You see, we are not radiologists. Most of you guys are gastroenterologists, I suppose. So you really need to understand what normal is. So it's only then that you'll start picking up what is abnormal. Okay, so that's why you need to see a lot, just stand and observe and understand and ask questions to your mentor. Okay, every patient is different. Okay, so this is something that you eventually learn. That in some cases it's pretty easy. You know, identifying structures can be very easy, but in some cases you can really try, and sometimes it may even get difficult or even impossible at times to identify certain structures. So don't lose sweat over it if you've done, like, say, a couple of 100 EUSs and then you don't find something, because maybe it's really hard to find it. So every patient is different. So don't lose your don't lose hope if you don't find sometimes a structure or two. So most of us, even after doing thousands, have some difficulty at times. Okay. All right. So I think Jayanta mentioned, air is your enemy. Suction. Can't tell enough. The artifacts can make life difficult. Water is your friend. Use it as appropriate. I won't go into much details. The other thing, when you do a diagnostic EUS, what's important is that one snapshot is not enough. People think that, okay, I went and I took a snapshot of the left lobe of the liver and I'm done. That really isn't enough. You know, you have to perform a thorough examination, which means you examine it in different planes. You get a sagittal view. You don't get the entire view, right? So you go through a CT scan, you don't look at the liver and say everything's normal. You go through all the sections from top to bottom. In a similar manner, in EUS, you have to rotate the scope. You have to examine thoroughly. You don't get one snapshot and get done with it, okay? When you have a doubt between ducts and vessel, you use your Dopplers to help you out. Anyways, we'll start with intubation, as Jayanta showed, and the ultrasound transducer at the end can make a slightly challenging intubation. So the view what you get is oblique. So just remember, you don't look in front like an endoscope, not side. There's a duodenoscope, so you get sort of an oblique view. and excuse me, get familiar with it, okay? You have a blunt front end, so be careful as you advance the scope, okay? And as you learn in most endoscopies, never push if there's any resistance, especially at upper esophageal sphincter or the D1, D2 junction. Those are the two areas where complications and perforations happen. Other areas are fine, but never push if there's resistance, okay? Why? Because sometimes at EUS, you're in a diverticulum, especially in older patients, and next thing you know, you will perforate the wall of the diverticulum by not knowing. So always, if you have a problem, pull the scope out, put your standard upper endoscope, visualize the diverticulum or whatever there is, if there's a stricture sometimes. So visualize, ensure what you're doing, and then put the scope back. So even after like so many years, still there are times when I feel resistance, I go back, ensure, look at the anatomy, go back, put the scope again, maneuver the scope appropriately, and get forward, okay? So we'll just, I hope one second, I'm just going to lower this. We'll have audio on full. All right, so, okay. So we're going to go ahead and intubate the esophagus now. So just like any side wing, now this is an oblique viewing scope. So you do get some views, not all. So I just go over the tongue gently, right? And I'm going to use my big wheel towards me. As I hit the back of the throat, going to use my torque, gentle right clockwise torque, and then gentle clockwise torque. And there you go. Now you're inside the esophagus, okay? So that was just a demonstration of how do you intubate. Now, there was a question in the chat box as well. So again, you do it just like a duodenoscope, and most of you probably are doing ERCPs by now, if you're planning to learn EUS. So you get it across the back of your tongue, and then with your big wheel towards you, and then push it till you reach the upper esophageal sphincter. At that point, what I find really helpful is, say, a 30 to 60 degree clockwise rotation of the scope, as that will help you maneuver the scope and get it across the upper esophageal sphincter, and then you're in the esophagus, okay? So that's what. So let's go through spaces. So first area we want to examine is the subcarinal space. This is basically, I'm going to show you two areas of mediastinum and how to get there. So one, as I said, subcarinal space, it's below the carina where the bronchi branches in the right and left. This is the space between the left atrium and the pulmonary artery. I'll just show you how it should be done. Please let me know if the audio is not proper or so, okay? Demonstrate to you is the anatomy of the mediastinum, where I'm going to show you how to find the subcarinal space, okay? So now, number one, we get the endoscope at just, so I'm going to push it out. What you see on the screen is now we're in the esophagus, just moving towards the stomach, right? Okay, so now we're in the stomach, so I'm going to suction out the air, pull back gently, and then I'm going to torque my scope. Okay, well, I'm going to, until I find the aorta, all right? So now what I've actually done is clockwise torque until I find the aorta. Now what that is, a long tubular structure going from right to the left of the screen, and that's the aorta, okay? Now when you find the aorta, what you have to do is go 180 degrees. So you look at the liver, there you go. Now it's about, so you're looking at the liver, and I'm going to then gently pull back, okay? What you will see on the screen is a pulsatile structure. Yes, so what you see, I'm pulling back. This is the left atrium on the screen, okay? So I'm pulling back. So what you're looking at is the left atrium, all right? What you need to do next is, again, pull back a little bit, and then I'm going to use my big wheel towards me and a little clockwise torque, pull back, clockwise torque, all right? Now what you see are two tubular structures, the one on the left of the screen, and I'm going to point it out for you, okay? So the one on the left of the screen, oh, okay, I think I lost it there. Yeah, so this one is the left atrium, and this one on the right is the pulmonary artery, okay? So in between these two, like this area right here, this is the subcarinal space, okay? So I'm going to stop the cursor. So you pull back, torque, okay? So this is the pulmonary artery, left atrium, and this region is the subcarinal space. You oftentimes find lymph nodes here for FNB or FNA in particular cases. Demonstrate. All right. So next area is the aortopulmonary window. This is the area underneath the arch of aorta. So this is between aorta and pulmonary artery. Okay. So, so I'm going to demonstrate how do we find the aortopulmonary window for the mediastinal examination. So firstly, we go in the G junction, we identify the aorta, which what you see is this anechoic structure here, right there. And just to show you that there's a lot of pulsatile flow in there, all right? And then what we do is we generally like to pull back, trace the aorta, pull back, pull back, pull back. So we try to go into the mid-esophagus here. Okay. Reach till the aortic arch, right there. So it's sort of ending there, as you can see. Okay. So when we reach there, we use the big wheel towards us. Okay, I'm going to do this again for you. Okay. Yeah, right there. So now here's the aortic arch where it ends. I'm going to use the big wheel towards me and push the scope gently in, okay? So here, this is the window. I'm going to show you what it is. This is the aorta, this is the pulmonary artery. This is the aortopulmonary window, all right? So this is where you find mediastinal lymphadenopathy in select cases. You may have to FNA those lesions, not in this one, okay? So I'm going to show it to you again. So we're going to go to the G junction, right? Stomach, we turn around, find the G junction. This is the celiac arch, this is the aorta. Then I'm going to pull back till I get to the proximal part. I'm going to pull back more till I see the aortic arch. Okay, so here we go. So it's the aortic arch there. And then I'm going to push a little bit with a gentle clockwise torque. Okay, here we are. So this is big wheel towards me. Can you show that big wheel towards me? And I'm going gently clockwise torque. Can you show the clockwise torque on the scope? Okay, clockwise torque on the scope, clockwise torque, and my big wheel is towards me. And there you go. So that is, this is the pulmonary artery, this is the aorta, and this is the aortopulmonary window. This is where we try to get lymph nodes. So I'm all right. So we'll just go forward to the next area. Now, the more sort of important structures that you end up having to identify on a more practical basis. So this is a station just below the G junction. You are looking at the aorta, celiac artery takeoff, the neck, body, tail of pancreas. You identify the spleen, the left kidney, the left adrenal gland, the venous structures, the confluence, splenic vein, SMV, the portal vein. Okay, so we'll just start this here. Okay, so what we'll do is we'll start with demonstration of the anatomy at the G junction. So what I'm going to show you is now I'm at the lower end of the esophagus, and the first important structure to identify is the aorta. Okay, so as you torque the scope 180 degrees, what you find is long tubular structure is the aorta. All right. I push the scope, move it back and forth gently with my big wheel towards me. I'll show you with the Doppler. This is the pulsatile sensations of the aorta, and I push the scope down, What you have to identify is the celiac artery takeoff. Okay. So here the celiac artery is coming right there. So as I torque the scope, it's coming slightly on the right of the screen. That's the celiac artery takeoff. And the crura of the diaphragm just over here. Okay. So now that's an important structure to identify. And as I see the celiac artery takeoff, then the next thing to do is to use your big wheel away from you. Can you show me the big wheel away from you? Can you show the big wheel away? Okay, so I'm doing the big wheel away.
And what you see on the screen is the pancreas, right? So this is the salt and pepper appearance of the pancreas right there. And while when you reach this point, you push the scope a little further and push it further. And what you have to do is gentle clockwise motion, okay? Can you show how I'm doing the gentle clockwise motion here? So while we are here in the counterclockwise, you see the neck of pancreas first. This is the neck of pancreas. And you'll see the portal confluence just below it. So this is the confluence, okay? So splenic vein, superior mesenteric vein forming the portal vein, okay? And then I'm going to do clockwise torque here, slow and steady, clockwise torque, and follow this. This is the pancreas, and you're going to follow the pancreas. You're going to follow the pancreas. Now I have my big wheel towards me with suction, and I'm going to do clockwise torque, clockwise torque, clockwise torque. What you've now reached the tail of pancreas, because now you see the kidney here. This is the left kidney. This salt and pepper structure is the pancreas. And then I do more clockwise torque, and I'm going to pull my scope back a tad bit. And now what you start seeing on the screen here is the spleen, pancreas tail, and kidney, all right? So you do more clockwise torque, and now you have reached the spleen and the tail of pancreas, right there. And what's important is to keep doing this counterclockwise and clockwise. So now what you're able to see is the entire pancreas from the neck, body, and tail region. And it's also important to go a little back and forth because you want to see the pancreas in all the planes. And right there you go. So yeah. And the more other important, the structure to be identified in the pancreas is the pancreatic duct. And I'll show you with Doppler where the duct is. I'm going to do clockwise torque. So this is a regular patient, non-pancreatic duct. It's slightly difficult to identify if it's really non-dilated, but this is the pancreatic duct here. This structure here has slight hyperechoic margins, but that's the pancreatic duct. And as I do gentle clockwise motion, I have to follow it as best as I can in the body tail region. So it's non-dilated in this particular case. All right. All right. So again, counterclockwise and then clockwise all the way down to the pancreas, kidney, tail, spleen. All right. Now, when you are at the kidney, the other important structure to identify is the adrenal gland. Okay. Remove the flow. So just pull back a little bit, and then you can do a slight motions. Let me show you. When you're at the kidney, between the kidney and the spleen, there's the adrenal gland. And what I'm going to do is at the kidney, I'm going to do a slight counterclockwise motion with big wheel towards me. And what you see on the screen, the structure here, this one right here, actually, let me use this. This is the adrenal gland. Okay. So this is the adrenal gland. It's a seagull-shaped structure right there. So now I'm getting nice views of the adrenal gland. Okay. All right. So that's one.
All right. So that's actually ends up being sort of one of the most important things that you have to do in the previous video is what we showed. So next station that you'll find structures is from the duodenal bulb. So here you're trying to locate the common bile duct, the portal vein, the hepatic artery, and course the common bile duct going down into the head of pancreas, identify the pancreatic duct. You should be able to see the gallbladder, cystic duct. The other location is transgastric near the antrum, and then the hepatic hilum with all that. So we'll just go ahead with the... Okay, so we're going to demonstrate how to visualize the head of pancreas. What I'm going to do is show you this maneuver from the duodenal bulb. So now my scope is in the antrum, and I'm going to advance it gently across into the duodenal bulb right there. I'm going to use my suction to move the air. And what you see immediately on the screen are a few structures. A large tubular structure, which I'll show you with flow. This is the portal vein, which is an important landmark to identify. And just proximal between the transducer and the portal vein, you'll find the bile duct, okay? So I'm going to remove this flow, and I'm going to use a clockwise torque, and I'm going to show you the bile duct right there. So
So to confirm with Doppler, this structure here, right here, this is the bile duct, okay? And we are going to show you how do we maneuver and course the bile duct. So here is the bile duct in the, right there, that's the common bile duct. And then we do a clockwise torque gently to trace it down to the head of pancreas. I'm going to use my big wheel towards me to show you the head of pancreas, which is right here on the screen, okay? So again, let's go back in to show you the portal vein and then the bile duct between the transducer and the portal vein. Oh, well, that's the hepatic artery. So yeah, right there is the bile duct. All right. So hepatic artery, portal vein. So this is the hepatic artery. This is the portal vein. This is the bile duct. Okay. And there you go to show you. This is the bile duct. Okay. All right. And then what we do is use my big wheel away from me, all the suction on the scope, and torque, clockwise torque, till you course the bile duct, going down, clockwise torque. It's going down, and then you see the head of pancreas, okay? So this maneuver, you can visualize the pancreas head and just really, gets sort of obstructed there in the head. You will not be able to visualize in this particular case till the duodenum, but you see that's the bile duct going all the way down, and we are seeing is the head of pancreas. So this is important for any beginner to locate, identify, and show the pancreatic head. And what I'll show you with Doppler is this is likely the pancreatic duct over there. Okay. Move the flow. So now, as we are at the duodenal bulb, what I'll show you is we trace the portal vein as we are.
So I think we'll move forward.
Okay, so we are going to demonstrate.
All right. So the next thing that you need to do is now you've visualized the pancreas from the neck, body, tail, and the head region. So the other thing that must be done in each case, and the pancreas examination is not complete until you do this, is the transduodenal examination across the second part of duodenum as you pull back the scope and visualize the uncinate and the deeper structures. And I've seen cancers being missed in this area and when the examinations are not done properly. So show you how it's done. Okay.
So let's look at the anatomy from the second part of the duodenum. So I'm going to advance my scope in the bulb. Next, I'm going to clockwise torque and push the scope gently so that I enter the second part of the duodenum, okay? Just how we do with an ERCP scope. I'm going to use my big wheel. I'm going to shorten the scope right there. So yeah, now my scope is shortened. I'm going to use suction. I'm going to remove all the air. Now with gentle clockwise torque and with the suction, we are going to start identifying structures. So you need to pay your attention to the right side of the screen. On top right, what you will see is the uncinate process of pancreas coming in the view. So that's your uncinate process. And I'm going to gentle pull back. The first anechoic structure, what you see on the screen, is the bile duct, which is closest to the transducer. So this is the bile duct, and the pancreatic duct will be just inferior to that, okay? So I'm going to do clockwise torque, bile duct right there, and then clockwise torque, anti-clockwise movement. So what you need to do is have a nice view of the uncinate process so that you can be confident in saying there's no mass, nothing is missed. There's a common bile duct right there, and then the pancreatic duct right at the bottom. This is the pancreatic duct, okay? This is the bile duct, and I'll use a Doppler to show and confirm that for you, right? So this is the pancreatic duct, and this is the bile duct, okay? Now, what we are going to do is go clockwise, counterclockwise torque, clockwise, counterclockwise torque. Now you're getting nice views of the head of pancreas, the uncinate. So as I said, this is the head of pancreas in the uncinate region. the common bile duct and the pancreatic duct opening towards the duodenum right over there. So we're going to do clockwise, counterclockwise motion right there, clockwise, counterclockwise motion. And what you will be able to see and appreciate is how well you can visualize these structures and really see them coursing all the way through the head of pancreas, okay? Just gentle clockwise, counterclockwise motion. There you go. All right. So remove the cursor. Yeah. All right. And that ends the examination. So,
all right. So I'm just going to move forward with the next part, just to identify the liver anatomy now. I think for most beginners, it's okay to identify the left lobe of the liver and the right lobe of the liver and the vascular structures. Doesn't end up being very practical. But as we are describing, we will show and share with you how these various segments of the liver are identified, can get important in therapeutic cases. So first we start across the gastric wall, just below the SCJ. And there's sort of 2-3 stations here that you need to know. So you need to look at the right hepatic vein and the IVC and the segment 1, 8, and 5. And then the left portal vein, the ligament venosum with the IVC, and the segment 1, 4, and 8 with the middle hepatic vein. And then ultimately the left lobe of the liver with the left hepatic vein separating second and third segment of the liver. Okay, so we'll start with the...
So what you're looking at on the screen is the inferior vena cava. And
so this is just below the squamocolumnar junction. And then we have rotated the scope to identify the liver and identify the inferior vena cava. Okay. So the large vessel coursing through the liver, as you see, is the inferior vena cava. And
the right hepatic vein over there, this one with the wide mouth opening inside the IVC. So the segment of the liver here, just between the transducer and the inferior vena cava, this is the segment 1. Between the inferior vena cava and the right hepatic vein, segment 8, and between the and below the right the right hepatic vein is segment 7. Okay. Now, when you reach this point, what you need to do is gentle counterclockwise torque. Okay. So as you can expect, the next structure, what you see is the middle hepatic vein. Okay. And just above the middle hepatic vein, extending from the left portal vein here is the ligamentum venosum. So this hyperechoic band is the ligamentum venosum. So again, starting with segment 1, and then what you see between venosum and middle hepatic vein is segment 4, and then below the middle hepatic vein here is segment 8. Okay, so 1, ligamentum venosum, 4, middle hepatic vein, and segment 8. Okay. Now what I'm going to do is more counterclockwise torque, more counterclockwise torque until we see the left hepatic vein now. This structure is the left hepatic vein, and just between the transducer and the left hepatic vein is the segment 2, and then below is segment 3. Okay, so there you go. So this is the left lobe. So,
so then as we finish the examination of the IVC, and then we can look at the hepatic hilum, and then the next station sort of to see is as you push the scope further down and look at the left portal vein and the segment 3 and 4, and then further down is the hepatic hilum, and I'll just show you how it's done.
View of the liver that you can obtain from here is the hepatic hilum. So now going back, so we are right here, the IVC and the right hepatic vein, and we do a slight counterclockwise torque to see the middle hepatic vein, which I showed you here. This is the ligamentum venosum, and this is the left portal vein. And I'm going to push the scope a little bit. Right there is the left portal vein. Okay. So when you reach this point, you're going to use your big wheel towards you, and I'm going to suction the air out, and I'm going to do slight clockwise torque. Okay. With my big wheel towards me. So this is the left hepatic vein, and then going to the main portal vein over there. And what you see is segment 3 over here and segment 4 over here. And this is the portal vein being formed at the hepatic hilum. I'm going to do a counterclockwise torque, and I'll show you a Doppler. This right here is the hepatic artery. This is the hepatic artery, the portal vein, and the common bile duct further down. Okay. Yeah. So as you push it down, so this right there, hepatic artery, portal vein, and then you further down, and then you can follow it down from there to the confluence.
Okay.
You.
All right. And then lastly, this is the last segment. So this is examining the right lobe of the liver. It can be sort of the more difficult segment to identify and see, as you have to torque the scope significantly. This is across the duodenal bulb. So you get the scope across the duodenal bulb, torque the scope, and follow the portal vein until it reaches the hilum, and see it branching out into the right and left portal vein, which is sort of shown in this illustration on the left. And then you further torque it sort of counterclockwise, and then find the right anterior and the posterior portal vein. And then you can see the different segments of the liver based on these two venous structures. And I'll just show you a quick video.
Let me demonstrate the anatomy of the right lobe of the liver from the duodenal bulb. All right. Now this can get challenging at times, but let's see. Now we'll get the scope across into the bulb. Right. So now we suction. And immediately of the back, what you see is this, which is a gallbladder. So what I'm going to do is I'm going to suction and then just do a gentle clockwise torque to first identify the portal vein. All right, so we're going to do a slight torque. Let me see here. All right. All right. Well, so here we go. So now what you see on the screen, this large structure with a lot of flow, this portal vein, you see the portal vein, you are going to clockwise torque. So towards the right, well, clockwise torque. And now you will reach the liver, okay? Now, this is the hepatic hilum. And the portal vein branches in the left and the right side. So the right portal vein is this going down here, and the left will go down here. All right. So let me see if I can show that for you. So there you go. That's the portal vein. Now this is your portal vein right here. This is a gallbladder. And then I'm going to suction, and I'm going to turn. So now it's going. Left is going this way, the right is going this way, okay? So now as you see the right portal vein, then you need to torque further out, okay? Now, this right here is the right anterior portal vein, and this is the right posterior portal vein, okay? The right anterior portal vein and the right posterior portal. And when you get that view, what you're really looking at in terms of segments is segment 5 here, segment 6 on this side, segment 7, and segment 8 on this side, okay? So,
all right. So
let me demonstrate.
Okay, so thank you for that. Thank you for seeing. End my presentation there. So basically, you know, of course, as best as we can in a virtual world, we've tried to demonstrate how this is performed. Those were live recorded, unedited versions and exactly how it's done. But of course, it's a matter of skill as to how it's performed. But I just tried to show you how the scope is maneuvered and the sort of movements that you need to do as you try to examine these structures. So I will open the session for all the panelists, and for you guys, if you have any questions about how it's done, and more practical tips that if you need, Shankar, please feel free to have your screen on if you would like. Yes.
There is some issue with my camera, Saurabh, but I'm here.
Never mind. So I'm happy to have you answer questions. Okay. All right. So we have some comments here. Dr. Bhandarkar is asking, is the CBD dilated here? Well, actually, that patient, the CBD was not dilated. It was about 5 mm or so. So I think one must recognize that what depth of field you're looking at, because if you are looking at a very a short depth of field, then all the structures look bigger. And then if your depth of field is more, then the structures look smaller. So I think depending on the case, what you're doing, in this particular case, it was not dilated. Okay. Okay. All right. Will this webinar be available later for watching? Yes, we'll use the recorded version. We'll put it on our social media platforms, etc. So Nishant Verma is asking, a harmonic SHD, when should it be applied? Jayanta, do you want to answer that? When would you want to apply it?
Yeah, sure. Whenever we have some kind of anechoic structures, lesions, let's say we are trying to find out the gallbladder, and then we find that there are some amount of noise artifacts coming around the wall, then in those situations, tissue harmonic helps in kind of reducing those noise and better delineate the structures. Sometimes there are certain kinds of side lobe artifacts that happen. So whenever there is an anechoic kind of or a hypoechoic kind of a structure, we get another similar kind of a anechoic area on the margins of this. This is known as the side lobe artifact. So these kind of artifacts can be reduced with the use of tissue harmonics. That can be done.
Okay, right. And then there's a question: how long is the learning curve for diagnostic EUS? Well, depends on how much hand you get on the scope and how much time you spend on it, clearly. But I'd say, I'd say at least 200 EUS before you can actually be confident in terms of at least showing the proper structure. What do you think about it, Jayanta?
Yeah, I think absolutely I agreed. It's definitely, it's not about the time, it's probably more time and as well as kind of.
Yeah. Shankar, what do you think? What's your thought on that?
I would certainly agree with you. Nothing less than 150 is sufficient. I think we need to keep evolving every procedure whenever we are early in the stages. Every procedure must be considered as we must try to identify all structures in every procedure. That keeps on adding. And I would definitely agree. Nothing less than 150 is sufficient at times for most of us.
Yeah, absolutely. Yeah. And I think I'd just like to add on one point, I think, is that, I mean, if you do 50 routine diagnostic with looking at collodical lithiasis will not help. I mean, also the range of kind of...
certainly.
Yeah.
And I would also comment, sorry, just...
Go ahead.
Just one thing. Because Jayanta has made a wonderful point that therapeutic EUS is easier than the diagnostic one. You need to spend a lot of time doing diagnostic, learning all the structures and abnormalities. Then therapeutic, just training in pseudocyst will be much easier than identifying an occult malignancy in uncinate.
Absolutely.
Yeah. I think the point is that I think you have to be thorough, understand, and also be thorough, and not rush through EUS, as a lot of people may do in their busy practice. Can get challenging for them. But as in when you learn, you need to be able to identify and then be very thorough and ensure that you actually do a good job at the examination. There's another question: how many days of observership required under mentor as a beginner, and how should one choose a center? I believe smaller centers better, you suggested, and Weiss. Okay. How many days? I don't know. It's hard for me to imagine like a 7-day exercise will get you up there into doing it. I think what you have to do is do multiple things. I agree. I don't think so. I mean, I think hopefully sessions like this give us a bit of a perspective, but of course it's not enough, and you have to probably do multiple week-long sort of observerships, if I may, and then go back and forth. In my opinion, maybe if you're not under a training program, then maybe just observe for a week, go back at your center, do it a few times, go back for another observership, pick up from what you learned, build on it, then exercise that and then go back, and maybe a few sort of going back and forth may make a difference in the setting of not having a dedicated training program for you to get into. A smaller center, well, I wouldn't know about that, which centers would be good or not. But certainly somebody who knows what they're doing is important. Smaller or larger shouldn't matter. Any thoughts, Janta?
Yeah, I think I absolutely agree with you. The only other issue